gain. And we have a study in press now with the Silver Journal showing the same, that in a non-random assignment study, stimulants did not attenuate either weight gain nor cardiometabolic lipid and glucose changes in children and adolescents treated with atypical antipsychotics. Conversely, on the next slide, it seems that co-treatment of atypical antipsychotics that are medium to high risk, risperidone, olanzapine, or quetiapine, with mood stabilizers lead to more weight gain than just mood stabilizer treatment alone, or even than just antipsychotic treatment alone, although the numbers were too small to show a statistical significantly different result for the atypical antipsychotic mood stabilizer combination against atypical antipsychotic alone. But there is an indication that there could be an aggravating effect in the interaction. Let's move to metabolic effects. I've already mentioned some of them. Patients with mental disorders, the kids already have quite a bit, if they're chronically treated, of metabolic issues. This is Nick Patel's study here from Cincinnati, showing that in hospitalized patients, 95 of them cross-sectionally looked at, basically 53% have overweight, which is the old name for obesity. Another 16% are at risk for overweight, which is the term now used, is basically the overweight category. And that means that 2/3 of patients are either overweight or obese. 50% of patients have some problem with HDL or triglyceride elevation, which is a huge problem. But we, with our medications, actually alter this to some effect, so to some degree. On the next slide, you see a study from the Spanish group, non-random assignment, 68 patients comparing risperidone, olanzapine, or quetiapine in psychotic youth. And what you can see is that the body weight increase was the largest, again, with olanzapine or risperidone. Not so much with quetiapine, but interestingly enough, the total cholesterol signal was significant for olanzapine and quetiapine. And we've seen that in adult studies too, and then also in the study that is now coming out in JAMA, that quetiapine seems to have an additional lipid signal that risperidone doesn't have to the same degree, despite the fact that in our study, even both groups gained similar amounts of weight. Looking at the TEOS trial, where unfortunately not too many patients had fasting levels, there was a signal again that olanzapine led to greater increases in lipids and also in liver enzymes than the other groups, as well as with insulin, whereas the prolactin elevation was the highest with risperidone. Let me shift gears and come now to the issue of having seen all of this, that these medications are effective in kids that need them for severe mental disorders, but they also have potential side effects. What should we do about these side effects? How should we monitor and manage them? And basically, on this slide, there is a summary of the current recommendations for monitoring of patients who are on antipsychotics, and I would also extend that to any weight-inducing medication. Many of the mood stabilizers, maybe with the exception of lamotrigine, can cause weight gain. And what we need to do at baseline and annually is a personal and family history assessment. At every visit, there should be lifestyle monitoring and instruction, as well as an assessment of height and weight, somnolence, and related problems. And then this information needs to be then included in our treatment plan. At baseline, during titration every 3 months, sexual side effects and symptoms should be monitored, as well as blood pressure and pulse. And cardiometabolic side effects like glucose increase, fasting, or changes in lipids need to be monitored at baseline 3 months and 6 monthly, because kids seem to be at higher risk for these changes compared to adults, where the current guidelines stipulate baseline 3 month and then annually assessments. Basically, prolactin is considered only a target for monitoring at the moment when there are suprathreshold side effects, because we don't know what non-side effect producing levels of prolactin really mean. That would be subclinical or clinically silent prolactin elevations. And EKGs, maybe with ziprasidone in kids because of the potential for more QT prolongation at titration at max dose, and also in clozapine treated patients at baseline, just to make sure that we're able to pick up if some cardiotoxicity occurs. The assessment of body composition on this slide needs to follow developmental guidelines, which means these kids still grow. So weight change is dependent on baseline weight and on growth. We need to do not only weight and height like BMI change. That is only good for the first 3 months where growth is not as important. After that, we need to assess BMI z-scores and percentiles. BMI percentiles can be used, like on this slide, seen on this slide, to categorize people into normal weight, underweight, overweight, and obese. So underweight is less than the 5th percentile, normal 5th to the 84.9th percentile, overweight is 85th to 94.9th percentile, and then obese is 95th percentile or higher. BMI z-score should be used for tracking of weight change over time because the percentile is cut off at the 0 and the 99th percentile. Waist circumference measures, which are very tightly correlated with cardiovascular outcomes in adults, are not currently recommended to be done in kids, simply because they are just hard to do, and you also need to follow a very careful adjustment for age and sex. So on this slide you can see the web-based calculators that are available for calculation of the BMI z-score and the percentile. It's very easy. You just plug in the sex, the age of the kid with the decimal, and the height and the weight. And this is something we should all do when we follow patients on weight-inducing medication, or even, for that matter, weight-reducing medications like stimulants. Blood pressure and other cardiometabolic measures are here displayed on this slide. We need to use different cutoffs for hypercholesterolemia or hypertriglyceridemia, which is 170 and 110 milligrams per deciliter respectively, rather than the adult rates of 200 milligrams per deciliter or 150 milligrams per deciliter. In terms of looking at insulin resistance, the best measure would be drawing also fasting insulin levels and then multiplying this by the glucose level and dividing it by a constant of 22.5. That's the HOMA, the homeostatic model assessment. But few of us do that. Insulin is also not a standard test. So a proxy measure of insulin resistance is actually fasting triglyceride divided by fasting HDL cholesterol. And that ratio then should not be higher than 3.5. But it can also be used to track changes in insulin resistance over time. It's just a proxy measure, but it seems to work rather well. But as I said in the monitoring, on the monitoring slide, we need to consider healthy lifestyle behavior very much. We need to monitor it, but also, like displayed on this slide, we need to educate our patients. We developed a 12-step program. There is an AMA program that is very similar, that's available on the website, where step 1 follows also just the simple instruction model, but it's relevant that patients and families realize that certain things that they might consider being good for weight loss are actually counterproductive. For example, diet soda can increase metabolic syndrome and appetite much more than water, or people who use less diet soda. So that's relevant to know. They are being marketed to reduce weight, but they can actually increase weight. Similarly, particularly sugared drinks, soda, juices should be cut out, and water or unsweetened tea should be used. Then also fat-free foods actually contain a lot of high degradable sugars and carbohydrates, which can also increase craving later on because of insulin response. So those processed fat-free foods should also be cut out. And obviously having more fruits and vegetables and exercising more, having more meals with the family and less fast food meals, not skipping breakfast, having frequent small meals. These are all rules we need to tell our patients and actually monitor over time whether they are following this. Now, many of our patients can't do all of these things, so what I do usually is I go over this list, identify where are they most off the chart, and then let them pick one item that they feel they can address the easiest until I see them the next time, and then move down the list. So what should we do when we treat patients with these agents? I think